channel viewers. In today's video tutorial, we have covered in detail about the recent advances in the management of gastric cancer. Highlights of this video tutorial will be AJCC classification, anatomy, TNM staging, the lymph node station according to the Japanese classification, the extent of lymph node dissection as per the Japanese latest classification, lab versus open distal gastrectomy in early and advanced gastric cancer. Then we will discuss about perioperative chemotherapy and reconstruction option and Korean practice guidelines that we have covered in the last part of the video tutorial. So now viewers, we will discuss in detail about the different lymph node station and we'll try to understand the concept of D1, D2 and D2 plus lymphadenectomy as per the Japanese classification. In the Japanese classification, the lymph node stations for the gastric cancer are divided from 1 to 20 stations, and there are 3 additional stations for GE junction tumor, that would be 110, 111 and 112. So for the purpose of simplification and to remember the lymph node station, 1 to 6 lymph node station are perigastric, that means they are along the wall of stomach, and in which 1, 3, 5, that means all the odd numbers are along the lesser curvature towards the right side, and 2, 4, 6 are along the greater curvature, that is towards the left side. So 1 to 6 are perigastric lymph nodes. 7, 8, 9 they are celiac axis branches node, and 7 is left gastric, 8 is common hepatic artery, and 9 is celiac trunk, 10 and 11 is splenic, and 12 is hepatoduodenal. I have covered all the lymph nodes in detail, so let's get started. So 1, as I said, it is odd number towards the right side. It is right paracardial lymph node, including along the first branch of ascending limb of left gastric artery. Second is left paracardial lymph node, including along the esophagocardiac branch of left saprophrenic artery. 3A, 3B, these are the lesser curvature lymph node along the branch of left gastric artery and along the second branch of distal part of the right gastric artery. The lymph node station 4 is divided into 3 parts: SA, SB and D. SA is along the short gastric artery, that are the branches from the splenic artery, and SB is left gastric left greater curvature lymph nodes along the left gastroepiploic, and 4D is right gastroepiploic artery. So SA short gastric, SB as per the anatomical position, SB left gastric, left gastroepiploic, and D is right gastroepiploic. 5 is suprapyloric lymph nodes along the first branch of proximal part of right gastric artery. 6 is infrapyloric lymph node along the first branch of proximal part of right gastroepiploic artery, down to the confluence of right gastroepiploic vein and anterior superior pancreaticoduodenal vein. 7, as I said, these are the celiac axis lymph nodes 7, 8, 9. So 7 is lymph node along the trunk of left gastric artery between its root and origin of its ascending branch. Station 8 is A and P. A is anterior superior and P is posterior. B dissect usually anterior superior lymph node only, that is along the common hepatic artery. 9 is celiac trunk lymph node. 10 is, now we go towards the splenic hilum. The splenic hilar lymph node, including those adjacent to the splenic artery, distal to the pancreatic tail, on the roots of short gastric artery, along the left gastroepiploic artery, proximal to the first gastric branch. 11P, 11 is splenic artery lymph nodes. 11P for proximal and D for distal. Proximal splenic artery lymph node 11P from its origin to halfway between its origin and pancreatic tail. And 11D is distal splenic artery lymph node from halfway between its origin and the pancreatic tail end to the end of pancreatic tail. 12, these are all hepatoduodenal ligaments. All hepatoduodenal ligaments are station 12. It is similar in the CA stomach and CA pancreas also. Lymph node station numbers remain same whether we are operating for a CA pancreas or gallbladder or esophagus or gastric cancer. So once for life we have to remember these lymph nodes by heart, and if we understand the anatomy, it is easier to remember these lymph nodes. So 12, as I said, it is a hepatoduodenal ligament lymph nodes. A, B, P, it is an acronym. A is arterial, B is along the bile duct, and P is along the portal vein. So A, B, P, hepatic artery, bile duct and portal vein. Lymph node 13, which has been classified as non-regional lymph nodes in AJCC, is posterior surface of the pancreatic head cranial to the duodenal papilla. 14V is lymph node along the SMB, and 15 is lymph node along the middle colic vessels. So station 16, these are the para-aortic lymph nodes, and A1 is para-aortic lymph nodes in the diaphragmatic aortic hiatus. A2 is para-aortic lymph nodes between upper margin of the origin of celiac axis and lower border of left renal vein. 16B1 and B2, these are para-aortic lymph nodes between the lower border of left renal vein and upper border of origin of inferior mesenteric artery. And 16B2 is para-aortic lymph nodes between upper border of origin of IMA and aortic bifurcation. 17 is lymph node on the anterior surface of the pancreatic head beneath the pancreatic sheath. In the case of CA head of pancreas and CA gallbladder, we usually sample the intra-aortocaval lymph nodes, and that will be station 16B1. So that we have to remember that para-aortic lymph node, that aortocaval lymph node that we usually sample during the extended cauterization maneuver that we have covered in another video tutorial. I will share the link for that video tutorial in this in the description and in this video also. So 16B1 we usually sample in gallbladder, and if we talk about CA stomach, these are part of the D2 plus lymphadenectomy, and we have talked about this thing, but to briefly, these lymph nodes D2 plus lymphadenectomy, that is D3, D4, these are not recommended because literature doesn't support, because there is added morbidity and it doesn't add to the survival benefits. Station 18 is lymph node along the inferior border of pancreatic body. 19 is intra-diaphragmatic lymph nodes, predominantly along the subscenic artery. That will be more important when we are talking about the G junction tumor. 20 is paraesophageal lymph nodes in the diaphragmatic esophageal hiatus. 110 is paraesophageal lymph nodes in the lower thorax. 111 is supradiaphragmatic lymph nodes separate from the esophagus, and 112 is posterior mediastinal lymph nodes separate from the esophagus and the esophageal hiatus. So when we talk about 110, 111, 112 and station 20, these are more relevant while we are treating a case of lower G junction tumor, that will be severe type 1, type 2 and type 3. So once for a lifetime, just go through all these lymph nodes time and again and remember them by heart. And I have also given the pictorial description in this video tutorial. I hope that will help you.